Hi, I'm Hsien
And I'm Sammy Winemaker. We talk to people who have information and tips on how to unlock a better illness experience.
The waiting room revolution starts right now. Welcome back to the waiting room revolution. Today we are welcoming Dr. Mark Levine to the podcast. He is a medical oncologist for breast cancer patients and is an internationally renowned researcher in clinical trials for cancer. And he's led the Regional Cancer Center in Hamilton and was the past chair for the Department of Oncology at McMaster University for many years. He was my old boss and my good friend. Thanks for being on the show today, Mark.
It's my pleasure. You may not say so an hour from now, but I'm very excited about being here and being able to share my thoughts with you and Sammy.
I know you have listened to season 1 of the podcast, which was designed for patients and families, really. But we always appreciate hearing what frontline clinicians think of the messages in the waiting room revolution. So let's start with your reactions to the podcast so far.
And my initial response was, like, this is fantastic. This is like somebody finally gets it. But I've thought more about it, and there are a lot of caveats to it. Mm-hmm. So the idea that, that palliative care, supportive care, is you only call for help in the last 2 weeks of life, and nobody knows. People aren't prepared to receive it, and stepping back and getting patients and families to understand that the culture that they've been in oncology is one of intervention, mm-hmm. and that intervention per se, is a good thing. But there comes a time where the best intervention is not to intervene. And that doesn't mean your doctor or your nurse or whoever isn't going to care for you anymore, isn't abandoning you, et cetera, et cetera. And I think your podcast about the importance of understanding of where you are in your disease trajectory, a true understanding, and managing that is the context of what you're talking about, and it's a very empowering the patient and the family to do that is very clever and innovative. It's also very scary. Yeah. I'm sure it's very scary for people.
One of the reasons why we are very excited to have you on the show is because you've been a frontline clinician, a medical oncologist, treating breast cancer patients for 40 plus years. And we get to pull back the curtain a bit and understand the thinking of a cancer specialist. And plus, you recently retired, and so you can be open and reflective on your career and where the state of medicine is today, but also where it needs to go. So I'm hoping I can ask you to reflect a bit on your many years of practice and maybe how it has changed from when you started.
It's typical of many oncologists that I probably was one of the most aggressive chemotherapists in Canada in the beginning of, in the 80s and 90s. That's kind of, and then over time, I learned about communication. I came to appreciate what's important, what's not important, and I would say in the last couple of years of my practice, people laughed at me because I was the least aggressive. I came full circle, but I prided myself on trying to develop a rapport with the patient and their families, communicate, do the best I could. Many of those try not to give fourth and fifth and sixth line chemotherapy, not to get angry at the patient when I'm frustrated because basically the cancers, the treatments aren't working. It's not the patient's fault. So those are and so you come full circle, and I see that with many oncologists. They start off very aggressive, and they end up sitting on the REB or becoming palliative care doctors because they've come full circle in terms of what's important, what's not.
Maybe you can elaborate more on why you think having open communication is so difficult for clinicians?
The more I've thought about it, is it's very complicated in the sense that, you know, I've had people with metastatic cancer come to see me, and I've said to them, you know, your cancer is spread. Um, I can't cure this, or we can't cure this. The goal is to try to control the cancer to, to maximize your quality of life for as long as possible. Sometimes the patient doesn't want to hear that and they fire me. It's happened.
Mhm.
What's the matter with this doctor? He doesn't want to treat me. That's the message they get. And they go, the next day you get a message from the family doctor. Please find another oncologist for the patient. So there's also that, that it's a lot more. I mean, there has to be a change in how we think of, you know, medicine, and that we're not always interventionalists, and it's also the patient's perception of us as well.
I really appreciate your honesty, but I really do. It is so rich to hear someone from your perspective, reflecting on your career and the content of the podcast. Um, it's um, it's a unique opportunity to
Mhm.
interview someone like you for sure.
No, but there are, as you know, there are oncologists who are not comfortable sitting down with the patient and family, holding their hand and saying, "Look, this another course of chemo is just going to make you sick. It's going to make your last 2 weeks miserable. I'm still going to take care of you. Just giving up on the drugs doesn't mean I'm giving up on you." And there are lots of docs like that, and it's not for me to judge them in any way, and I'm not trying to. Um, um, I admire, these oncologists that have huge practices of people with advanced cancer, and I don't see how they actually have the fire left in them to continue, because it's a really, it really consumes you. So, uh, but I think we need a new way to deal with this, and one way of it is educating the patients and the families. And I think that's what you're empowering them, which I think is the self management and all that's very trendy these days. But it's a new way of doing this. It's not going to, it's going to, even if it, captures a small segment of the population, it's constructive. It's 10%, 15%, 20%. It's we get caught up in all this targeted therapy and all this, high fancy schmancy stuff, and we tend to forget some of just the basics of communication and hand holding. I mean, virtual care, you can't see or touch your patient, but it's really important. It is so important.
You know, you had mentioned something about the idea of patients being empowered or activated, um, or the idea of talking about the truth and the reality of someone's situation as being scary for the patients and families. Do you think it's also scary for the physician?
Yes, I do, for several reasons. One reason, as I said, is we're trained to intervene with, I don't know, medicine, surgery, whatever. We don't get the best training in how to intervene with words. Um, and I would say it's even worse now, because the trainees are all fantastic with technology, but ask them to do a history and physical, they can't. Ask them to go and look at a patient from 10 feet away. A really seasoned clinician will say that patient's depressed. Just I could, when I was practicing, I could look at a patient. That's all I needed, uh, to get a feel for what was going on. A little bit more, talk to them. That's so important, and that's gone by the wayside. I mean, my God, there's really a lot of bad things about this pandemic, but I'm not convinced that virtual care is they say it's here to stay. It's da 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 da. but the empowering the caregivers is going to be is being lost, and I think in fact, Sammy, it's those caregivers who are not comfortable with that's how your question began, are not comfortable, are threatened by the honesty of being saying I can't do anything more, I can't intervene. The virtual care is they're loving this because it's distancing them more than making increasing the gap. And as you know, there's no perfect. Actually, Mac has done some really leading work in the world and try to how do you identify people who are going to become good doctors, and it's a crapshoot. It's a crapshoot, and you identify people who go into med school. Many of them, just are not don't have the character, the training, to be the empathy, and uh, um, that's the challenge. And as you say, yeah, it's very threatening to them, and some of them have had obviously negative family experiences with cancer, chronic end stage renal failure, or heart disease, where palliation is important, and it brings some of that sort of stuff back. So, um, and you've hit it on the head. I mean, um, it's much more enticing and sexy for a young trainee in oncology to learn about targeted therapy, to learn about immunotherapy, SBRT, all these fancy things, as opposed to, how do I communicate and have that discussion about um, the very difficult discussions. I'm not talking about end of life, and that's difficult, but patient comes in with metastatic colon cancer or metastatic breast cancer. The doc knows they're not going to be here in 2 years. Well, how do you communicate that compassionately without taking away hope? Very, very difficult.
Mm-hmm. Mm-hmm.
But I'm hoping that I would hope that, and I think this is work for all of us. Is there are some oncologists, physicians, nurses who might be threatened by the work you're doing because it's an expose, if you will, in some ways,
Yeah.
and it shouldn't be. It should be a way of, in my view, of no one's trying to be critical. The idea is here's another pathway to follow.
Mm-hmm.
Here's another way to change behavior. Here's another way, the context. And there's been a lot of discussion in the oncology literature, as you know, about, I put this in quotes, early integration of palliative care, whatever that is. But and it's not the easiest thing to do, but communication is key to it. And if you're afraid to talk to the patient about these really difficult situations, um, it's tough.
You're connecting closely to some of the keys we talk about in season one, walking two roads, and helping patients know you can hope for the best and plan for the rest, and that it doesn't mean giving up hope. And that's such an important thing to talk about, even if it feels uncomfortable. I'm curious that we really encourage patients and families to invite themselves to the conversation, and in some ways, to declare their informational preferences and their style to their doctors and healthcare team up front. So things like informing them if they're the kind of people who like a lot of information and like to plan ahead or don't want things to be sugar coated. These are all things that are helpful to know early on, I think. And I wonder, looking back on your clinical encounters, did you have patients and families say that to you? And if they did, would you have been receptive to that?
I would say, like, if you think about this as a bell curve, what you've described would be one edge, one DV. That's, let's say, 10 or 20%. That's a minority. And at the other side is the person the group that, come hell or high water, they're not going to believe you. They want to be cured. And in between, I think, is the average person who, when they're hit by cancer, severe cancer, they're just numb. And they're, despite all this stuff about trying to do shared decision making and stuff like that, they're numb. They're waiting for a plan. They're waiting for direction, they want to be kind of told what to do. And I'm not saying that's right or wrong, but the reality is those are the most of the kind of people you're dealing with. And if you can bring them, so you have the point I'm trying to make is you have a chance. The slate is they're coming to see you. They're just numb. The slate is cleaned. If you can somehow prepare them, you're going to be with them for 2 or 3 years through their illness, and you can actually prepare them and build up the rapport so that, over the next 2 or 3 years, things may not go well. Let's have those discussions and let's not be afraid to have those discussions. That's kind of what I tried to do to sort of, you know, guide the people and help them along so that we could have those discussions. Um, um, and sometimes it worked, sometimes it didn't work. I think the kind of person also you have to be very careful. The kind of person that you described, in fact, who may be coming in saying, I want to know everything. I want to have that discussion. In fact, the truth is they want the very opposite. They don't want to hear anything. They're afraid, and that bravado and that is in fact the opposite of what they want. And that's why I think I'm still coming back to you have to try to develop that rapport with the patient and family so you can have that level of comfort before the last 2 weeks of life. And if they'll let you, guide them towards that sort of uh, kind of thing you talk about in the experience you talk about in the podcasts. I think I don't have to tell you folks that changing behavior is, and I don't care if we're talking about patients or families or physicians or not. It's really hard. I think that's one of the hardest things in not only medicine but in the world is just changing people's behaviors. I mean, and that's what you're trying to do with the podcast. And hopefully you will. It will help.
It's very interesting because from what I can tell, there are really good guides out there for clinicians on how to speak to patients more openly and frankly. There are courses you can take, there are books you can read, there are simulated patients, people in medical school practice on each other. But I think you hit the nail on the head, actually, a couple of minutes ago when you said something about the timing of it, the prompt. It turns out that you can teach doctors how to speak beautifully, but then there's still this challenge of when to do it in my practice. It seems to be the biggest challenge. And
You're absolutely right, Sammy. Because I actually I remember when all this material about early integration of palliative care came out, I actually tried to raise the topic in some discussions with patients who had just developed metastases and sometimes, about goals of care, expectations, and sometimes it worked and sometimes it really backfired. And no, but I agree with what you're saying, and I think stimulating the discussion by what you're doing through your podcasts, it would be, it's another tact that you're trying, and it would be very interesting if you could somehow monitor or have examples where, oh, somebody heard your philosophy, if I can call it that, and they actually tried it on their care team, and this is what happened. Hopefully some of them would be very successful in opening that discussion.
because if you miss the opportunity to integrate some of these discussions earlier, that's when it becomes harder and harder and scarier as the person edges towards the cliff. And then you end up in this situation where you're gulping because you have 50 people in the waiting room, and some of them are coming in close to the edge, and we've missed the trigger to talk
Yeah.
about it
Yeah.
sooner.
Mm,
Yeah,
yep.
because it's so uncomfortable.
Yeah. And no, I agree with you, and it's, I don't know if you go back in the history. Can I use the term palliative care movement? And maybe it's not the right term,
Sure.
but when you started, okay, i- palliative care was synonymous with pain control, and it's not. It's quite, oh, yeah, pain control is one part of it, but having the discussion is a very important part of it, and I think that's something we've learned over time, and as the specialty has evolved. Um, but it's not sufficient. Just it can't be a specialty. It has to be, um, it has to be what's practiced throughout by family physicians, oncologists, nurses, stuff like that. The idea of the consultant and then turning it over to somebody, it works if they know what they're doing, but if they don't, it's not so good.
Mm-hmm.
I mean, I don't know. I'm going on, but it's a very what you're the topic you're tackling is difficult. There's no right answer.
Mm-hmm. And it becomes more awkward the longer we avoid it. But, I can share with you that most patients do appreciate the invitation to know more. And I think that's where people get held up. Um, there's nothing about having to tell someone their prognosis. We don't have to force people to know. But I can tell you that most of the patients I've met really appreciate the invitation to know that we know something.
Mm,
I know what the next years are going to look like for you, generally speaking. Are you the kind of person who would like to know, or are you the kind of person who would rather not know? It's about sharing that I have information. What do you think of that, Mark?
that's you're painting the ideal to me. As I undoubtedly that would for that's the ideal in my view situation where there's the patient is interested. There's this free flow back and forth about this very complex but difficult subject. Like many of the people that come in are just in shell shock, as I keep saying, and they're not ready for it,
Mm-hmm.
even if they got advanced pancreatic cancer and it's
Mm-hmm.
all over the place. It's just, um, uh, and in some of those people, forcing the discussion sometimes helps, but sometimes doesn't help. And yeah, to me, it's what you're describing is the ideal, something that a goal, but it's not going to work in all scenarios. And if you use the prompt, if you push in that direction, and you meet resistance, then it's for another day.
Mm-hmm.
Mm-hmm.
So
Mm-hmm.
I just don't think it's as black and white, Sam. There are
Mm-hmm.
certainly patients that where that scenario is applicable, but there's others that where it just you wish it was that simple. And then you go in now into our multicultural society. It you have to tailor
Mm-hmm.
some of your you know, some of your what you do to where the person's ethnic origins are,
Mm-hmm.
because they have some very interesting views about from their life experiences.
Yeah, sometimes I'm going to admit that I have been resentful, at the 11th hour being in someone's home. And this is really how this whole movement started, based coming from my resentment, not towards you, of course, but generally speaking, there were too many times where I would meet people who were very close to death, um, who told me, you know, I need to get stronger. I need to, my doctor told me if I'm not stronger, I won't get more treatment. Or if I don't gain weight, I won't get more treatment. I need to eat more, but I simply can't. I have no appetite. In fact, it's making me feel like I want to throw up. And every time I try to exercise, I collapse because I just can't. And of course, in my mind, I know it's because this is normal. You are dying. Your body is slowing down like nature
Yeah,
intended it to. But some people before me have set you up to have false hopes that don't match where you're at in your illness. And I think that's the biggest risk is when we avoid these conversations, hope and reality get mismatched. And then,
absolutely.
you know,
I think one of the very upsetting examples of that, and that's another reason I got out, was technology. So now, in the cancer center, they have these fancy mancy cyber knives and whatever the hell they're called, these radiation machines that can deliver radiation with precision so that the tissue around can be spared. So you see a lot of Sammy patients with either primary brain tumors or metastases to the brain. So it used to be you'd get one shot of radiation, and that was it. You manage the patients with steroids until till the end. Well, now what they're ending, with a person with 3 or 4 Mets, they're radiating each Met, and then they do a CAT scan or MRI in 3 months, and if it's got a little bigger, they'll radiate it more. So this goes on. It's not affecting the natural history of the disease. The patient is still going to die of the cancer, but it's creating such a disconnect between the patient's expectations. The whole example of technology and the idea of, docs are really good at intervening but not dealing with it is I think, whether it's the surgeon, whether it's whichever phenotype we're talking about, it really are it's a problem. Technology is setting us up for the poor patient is just totally disconnected from
mhm.
reality. That should be another chapter.
You know, one thing is, as I'm listening to you talk, you meet people at such a different point in their illness than I do. Um, and, by the time I meet them, I can only plump them up, with the good news of better symptom control or, you know, um, discussion about helping them connect the dots, whatever it is. Um,
Mm,
I usually meet them at a very low point, and we can only move up together, really, so to
mm,
speak. Um, but, when I think about my oncology colleagues, I do appreciate, and same with my family medicine colleagues and other specialists, that you journey with patients a lot longer than I do. Um, in the current healthcare system, and you often take them from what could be curative to recurrence, metastatic, advanced, end stage.
mhm.
And I just really appreciate that, the relationship that you build with your patients and families makes it that much harder to bring them along the journey and have to break the bad news. That must
Y-
be soul wrenching for an
yeah,
oncologist. Oh, I guess what I was
uh,
going to say is, like, when people have ALS, for example,
yeah,
that comes with a very well known illness pattern and a timeline. But with breast cancer, like you said, there are so many different paths people can go. Um, and many women with breast cancer have every right to believe that their breast cancer is curative. So the fact that you meet such a mixed bag, let's just say, with people who may be cured or may not be cured, I can just imagine that taking its toll on someone over a 30 plus year career.
yeah. The other thing I've seen the way oncology is practiced, not really, uh, in Canada so much, but or like the way you'd see it done in remote communities up north, is that basically the cancer center is for, you're acting as, if I can use the term, technicians. You're giving, let's say, take breast cancer. You're giving the upfront chemotherapy and radiation. Then the patient is, discharged to the family physician, and they're followed by the family physician. And then if the cancer comes back, they go back to the cancer center. And I mean, that's one way that oncology can be practiced. Unfortunately, I family currently with our healthcare system, I don't think family physicians have the time, or some of them might argue, but it's not ideal for them to be doing, for patients to be treated at a comprehensive center and then just transferred over. But that some people might feel that's the right way. But right now we've managed to create a huge gap, in my view, between family physicians and oncologists. So there's no one to do the palliative care except you. You know what I mean? It's sort of like many family physicians will not take it on, even though they've known the patient for years. So um, who's to say? I don't know. I mean, you obviously are seeing the one spectrum, um, and even within that spectrum, the most difficult cases. So because of your expertise. So it's many ways to kind of look at this elephant kind of thing.
Mhm. It, yeah, there is this problematic pattern that happens when people are diagnosed with a progressive life limiting illness, let's say a cancer that's not curable. Um, and they're seen more and more and more at the cancer center. And you're right, this gap or chasm starts building between the oncologists and the family practice. And it's difficult to know who's on first and who's on second.
Mm-hmm.
Who's introducing and having these discussions with the patients and families? The oncologist might think it's the family doctor, and the family doctor might think it's the oncologist. And then suddenly we're not having them.
Yeah.
Um, so it is a big problem because, of course, once the patients can't get back to the cancer center, the expectation is that the family practices suddenly receive them again. So one of the
Yeah,
things,
and
yeah,
sorry, and that's not happening either, because so where does everybody ends up in emerge? The lowest common denominator. There's very few family doctors that make house calls, and you know with the complexity of some of these illnesses, the family doctor has the same problem. Well, he or she is not equipped to deal with all these different manifestations.
Mark, I'm curious. We talked earlier about how patients and families have their own style and should declare that to their healthcare team, like, the kind of person who likes a lot of information. But I also suspect that clinicians have their own styles as well. And they probably have their favorite ways or the patterns of how they approach certain conversations. And I'm wondering if you feel like you were ever changing your style or your pattern and how you would approach a patient conversation depending on the information style of the patient.
As Sam said, it really depends on the phase in the illness. So if you're starting at the early
Yeah.
disease, and you're making these decisions of treatment A versus treatment B, you spend a lot of time um, giving them a ton of information, even if they don't want it.
Mm.
You go through it. Then, as the disease, if it progresses and comes back, um, you obviously give options, but you wait. You also really want prompts from the patient. If the patient says, "Look, I've got, I've got, my daughter is getting married in a year's time. Am I going to make it? Da 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 da." Then you sit down and you really go through it with them, and you say, you
Mm.
know, um,
Okay.
many times I would say, my advice is get married, call your daughter, and if you want, I'll do it. I'll be there with you. Tell them we want to have the wedding in 6 weeks.
Okay. Yeah.
That's a very good way to, I think, many people would give you a life event that they're looking forward. They're bargaining with you,
Yes.
okay?
Yes.
And you have a chance to communicate the severity of the situation
Yeah.
by how you move those yardsticks. If you say, yeah, you'll be okay. Well, we can manage this for a year from now. Well, the cancer shouldn't be. Yeah, you might have no hair or whatever, but you'll be there for the wedding. Versus, you know what? Let's do it now. Um, that's a nice way of segueing into that discussion.
But I think that's a really another way of expressing your point, that one of the triggers to have the discussion is for the patient to come forward and ask you something. That does work often, whether it's will I be here next year for my daughter's wedding, or let me have it, I want to know everything. It can make it easier for the clinician to go there with them.
Yeah,
Hmm.
or I have one more year to work, and I'll get my pension. Or should I take my time off now to be with my grandkids? There's lots of, so we're, actually here we're coming up with a nice little sort of something you could put together as prompts, as actually concrete strategies that
Mhm.
could be used, that are not as sort of earlier in in this discussion, it was black and white, very,
Hmm.
but these are actually very nice triggers that are gentle,
Mhm.
Yes.
that could get that conversation going.
Yeah.
Mhm.
Yeah.
Mhm.
I like that. I like that.
I do
I,
too. Thanks. We'll take credit for it.
yeah. But I do think people get fixated. I know they ask about the time, and that's what we're scared. That's the crystal ball. Like, it's hard to know the exact date. Is it 12 weeks? Is it 16? But what we often hear is, okay, yeah, put the time aside. The whole of like, what am I going to be expecting? Um, with basically what is the decline going to look like? Is actually something everybody can prepare for. And I think this is actually more clear, not outside of cancer, but in, say, when you're someone going to a nursing home or something, or dementia, because there is going to be these losses along the way that are predictable at some point. And therefore, if you don't plan for any of them, you're really caught at the end with, like, so overwhelmed. But I feel like we really shy away from talking about those changes, the functional decline piece, the loss of independence, and what that's going to look like, and how to prepare for that. And that is independent of how much time. That could come over 5 years, that could happen over 6 weeks, but it's probably going to happen. And I think some people really have no idea about that. They will say, I have bought my plot, I have my will, I know what songs I'm going to sing, I'm ready for death. And yet they haven't thought of the idea of how am I going to go up the stairs, and what happens when I can't go to the
Oh,
bathroom. And
it's much worse than that, Hsien. So they have all of that spelled out, and then I would say to them, "Okay, I understand, and that's good." And I said, "Well, what's going to happen?" And the wife there and the children are there. I'm going to say, "Well, what's going to happen when you're at home and you're watching? You're sick, and you stop breathing?" And I say to them, I said, "What are you going to do?" And the husband or wife says, "Oh, I'm going to call 911." And I say to them, "That's the worst thing you can do, because you're going to, the ambulance people are going to come, and they're going to stick a tube in your chest, down your throat. They're going to bring it to emerge. And then they're going to ask you, the family, do you want this person on a machine or not?" And so that gets into the discussion about what to do, what it's going to be like, how am I going to die? And I'm people would commonly say, well, "How am I going to die?" Because they're afraid of pain. So I say to them, "Well, everybody, it's different, but what usually happens, people get weaker and weaker, such that they can't care for themselves, and they have to go to the bathroom with help, and even have a bedpan, and maybe they can't eat. And I go through it, and then I said, and people often drift off into a coma and have a peaceful death. And I say to them, you know what? I can guarantee you, if we work together, that I can. You might have some pain, but you're not going to suffer from pain. And that gives that's a discussion about another chapter in the book. This is, how am I going to die? You've referred
Mhm.
to it as a period of disability. and obviously you have to make that less medical. And people, when they're ready for that, that's a very good discussion, because that avoids this crazy business of if you're going to die at home, fine, be ready. No, do the right things, don't do the wrong things, and calling 911 is the wrong thing.
You might enjoy our last episode, which is all about what I call the space in between now and the time you're gone. You can call that dying. I call it the space in between, like exactly how things unfold over the last year of life. That's what we talk about in episode 9.
Next week.
Yeah, and I taking us back full circle to how we started.
Mm-hmm.
I think there's a lot of doctors, oncologists, nurses that aren't comfortable in that space. They just aren't comfortable about talking about it. We can go into a lot of reasons. There are also many patients who aren't comfortable in that space, or if they're not comfortable in that space, they're at least spaced out, so they're not ready for the conversation. But it's and the question is, how do you get both parties, the caregiver, the physicians and so on, and the patients? How do you move them a little bit more so that the gap is smaller? And I think that's a really good way to think about that. There's a gap, and how do you make the gap as small as possible? And I'm sure there's a lot of other pieces to the gap. It's not just doctors and patients.
Yeah.
It's family members, it's support care workers, all sorts of stuff. Yeah.
For sure. Mark, if you were able to give one or two pieces of advice to other oncologists to bridge the gaps about everything we've talked about, what would that be?
There's no you haven't lost the battle, or there's no skin off your it's not a bad thing for you to say to the patient, I've given you lots of chemotherapy. I don't have any more tricks, or if I have some tricks, they're not going to work. I want you to be very comfortable in your remaining days. I'll take care of you. I'm not going to give up on you, but I'm not going to give you medication. That's, to me, there's no harm. That should be pretty standard. I think that one should get to know your patient well enough so that you can have that discussion about goals of care before it's the last 2 weeks of life and you have to call Sammy and okay, how can we manage things so that those are my two and I guess my third comment is, if it's not going to work, don't do it. Don't do it as a substitute for having that discussion. I guess to shrink it down, the message would be, don't be afraid, be open with your patient. And I think that's a nice way to say, don't be afraid, be open. And probably the result of all of that is very rewarding for everybody.
Mark, the conversation was awesome. Thank you so much for joining us.
Oh, this was a delight. I thank you so much.
Thanks for listening. Please visit our website, waitingroomrevolution.com, to listen to our first season about the 7 Ps and to learn more. The podcast is produced and edited by me and Kayla McMillan. Our theme music is Maypole by Ketsa. Please rate, review, and subscribe to our podcast and help us get the word out.